Good afternoon. I'm Laura Chatterton. I'm the student nurse practitioner who will be performing the head-to-toe assessment today on our patient. I'm going to start by observing and assessing the patient's head, scalp, face, and skin. The skull, as I palpate, I'm looking for the shape. I'm looking for the normal contours and depressions that are expected. I'm feeling for any lumps, masses, or pain. Our patient's skull is normal cephalic and atraumatic. Scalp is notable for average hair texture and normal distribution of hair given the age of our individual. There's no known parasites or obvious signs of infection. Face, I see no involuntary movements, no masses, lumps, or edema. And the skin, what I'm noting is an even color and pigmentation. The texture and thickness appears to be within normal limits. There's no evident scars. And again, hair distribution throughout the skin appears to be normal. Next, I'm going to do the ophthalmic exam on our patient, starting with noting the position and alignment of the eyes and their structures. With the eyelids, I note that there's no droop or any lid lag. Looking at the patient's scleras, they look up, down, and side to side. I'm noting that the sclera is nice and white. Looking at the conjunctiva on both sides bilaterally, it is pink, which is a normal finding. I'm also not noting any opacities in the cornea or the lenses. I'm noticing that the iris margins are very clearly defined. As I shine the light on the side from an oblique, I'm looking for any concentric shadows, or sometimes they're also known as criscentric shadows. None of those are evident, so we have a normal response so far. Next, I'm going to test the pupils for their pupillary response. I'm going to note the size, shape, and symmetry of the pupils to initiate. Right now they are round, they're symmetrical, and they're roughly 4 millimeters in size. As I introduce light to them, I'm looking for constriction of the pupil, not only in the direct eye into which the light is shined, but also into the adjacent eye, which is a consensual reaction. What I'm noticing on this exam is the patient is looking into the distance. I have lights dimmed and I'm introducing that. I'm seeing that the pupils are constricting from a 4 millimeter down to about a 2 millimeter in size, that there is a brisk, direct, and consensual reaction. Therefore, our pupillary response is equally round and reactive to light. Accommodation testing is next. I'm going to keep my finger still. I'm going to ask the patient to focus on my finger and then an object off in the distance. As the patient focuses to the near finger, they're noticing, or what I'm finding is that the pupil constricts. As they're looking into the distance, the pupil dilates, which is a normal finding. Convergence testing, I bring my finger, which is at midline, in towards the nose to about 5 to 15 centimeters, and I'm looking for the eyes not only to move in a medial aspect, but also for the pupils to constrict again. The closer the finger gets, that happens, and that's a normal finding. I'm going to move on to the ophthalmic exam, or the fundoscopic exam for the patient. I'm going to be using my ophthalmoscope. With my right hand and right arm, I'm going to go in and examine the patient's right eye. I'm going to ask the patient to look right ahead, and I'm going to move into it at about a 15-degree angle, looking for the red reflex. I'm going to also look for the optic disc. As I'm looking at that, I want to note its size, its symmetry. I want to look at the size of the physiologic cup, which what I'm noticing is it has a diameter about less than half of that of the disc. I'm also looking at the color of the optic disc, which is kind of a yellowish orange, can go to a creamy pink. As I'm examining the eyes, I also want to make note that I am looking at the retina. I'm looking at the arteries and veins that supply it. I'm also looking at the macula, and I'm also looking at the fovea. For our patient here, I'm not noticing any abnormal findings. There's no arteriolar narrowing, there's no hemorrhages, no exudate, there's no AV nicking, there's no cotton wooling, and there's also no copper wiring noted. So our patient has a very good fundoscopic examination. Next, we're going to do visual acuity via the Snellen chart. Placing it 20 feet ahead of the patient, I'm going to ask the patient to, with just their right eye, then just their left, and then with both eyes open, read the lowest line on the chart that they can clearly, and then challenge that by reading the line right below that. I'm going to give the patient a reading based on their scores. 20/20 is perfect vision. You want to test a patient both corrected and uncorrected to make sure that you're observing for the right distance of reading in case they need to have a referral to an ophthalmologist. For our patient, with it 20 feet away, they're 20/20 with an uncorrected eye because this patient happens to have perfect vision. Moving on to the ear exam, next I'm going to do an otoscopic examination with my otoscope. What I'm going to be doing is looking at certain structures within the ear and making notes of that. To do the exam, I'm going to pull up and away from the ear. I'm going to go into the ear canal. I'm going to keep my hand kind of on the patient's cheek just to make sure that I'm not getting too close. In the ear canal, I'm looking for any foreign bodies, for any discharge, any redness or swelling, none of which I'm seeing. I'm also making note that there's minimal wax or minimal cerumen. Going down in a little deeper, I'm looking at the tympanic membrane. It's a pearly gray and shiny structure. The cone of light is shining brightly. Looking at the bony landmarks, I want to make note of the handle and the short process of the malleus. The light landmarks that I want to make note of include the umbo, of course the cone of light, which there's a good one on this tympanic membrane. I also want to look at the pars flaccida and the pars tersa, and I want to look for any perforations or other deformities, none of which are present in the right ear. Doing the same thing with the left ear, using that same basic movement. Looking here, again, I'm noticing no abnormal findings. Sorry about that. And again, just minimal serum on that ear canal. Otherwise, everything normal for the ears. Once I've completed that, I want to palpate the frontal and maxillary sinuses. I'm going to ask the patient as I palpate if they're noticing any kind of pain or tenderness. Any pain or tenderness, sir?
No.
Okay, very good. So we have no issues there. Next, I'm going to move on to an examination of the nose. I'm going to, again, use my otoscope, and I'm going to inspect the anterior and inferior surfaces. As I enter through the vestibule into the first nares, what I'm noticing is that the nasal mucosa is nice and pink. The septum appears to be midline at this point. There's no polyps. There doesn't appear to be any discharge. There's no redness or inflammation. Going into the next one, again, septum is midline. The nasal mucosa is nice and pink. I can see the lower and middle turbinates as I did in the other one. So far our nares looks to be patent and operating perfectly well. Moving on to the oral examination, I'm going to ask the patient to open their mouth. I'm going to inspect the teeth and the gingiva for color and any ulcerations. The oral mucosa is nice and pink. I don't notice any ulcers. I'm also looking at the dentition, which is good. The teeth are straight and white. There's no broken or missing teeth. I'm going to ask the patient to stick their tongue out and continue to repeat ah, ah. I'm looking for the uvula to be midline. I'm noticing that the soft palate rises and falls as the patient says ah. It does so symmetrically. Both sides of the posterior pharynx move medially as expected, and the tonsils are a grade 1. I'm going to move on to an examination now of the nodes. I'm going to palpate the preauricular lymph nodes, which are right in front of the ears. I'm looking for tenderness or any swelling. The postauricular are superficial to the mastoid process. The anterior are just below the jawline near the carotids going down. And the posterior are down from the ear down to the backside. The submental are just underneath the chin, a few centimeters from the tip. The supraclavicular and the infraclavicular, again, I'm not seeing anything. Palpating the axillary, the anterior, the lateral, and the posterior. I'm not finding any nodes that are tender. I'm not noting anything that's palpable, and therefore I would say we have no lymphadenopathy. Next, I'm going to look at the thyroid exam. I'm going to note any masses or pulsations from the neck. I'm going to palpate or feel for the structures. I'm going to feel for the thyroid cartilage or the Adam's apple, the cricoid cartilage, and then down from there the trachea. The thyroid isthmus is midline. The neck is nice and supple. As I stand behind and using my fingers, I'm going to just palpate the lobes by pushing side to side. I don't notice any enlargement of the lobes. Everything feels to be within normal limits. I'm going to ask the patient to swallow. As I feel the thyroid move midline, there's no deviations. It went up and down as to be expected, and my fingers moved in a symmetrical fashion during the swallow test. Next, I'm going to palpate for the carotids. I'm going to look at the neck medial to the sternocleidoid mastoid muscle. I'm going to place my index and middle fingers, and I'm going to palpate for the carotid artery, noting that the carotid arteries should not be pushed simultaneously because it could result in an abnormal compression of blood flow. Once I find the pulse, I want to check it out for thrill. There was no thrill in either one of these. There was actually very good amplitude and contour of the pulse wave. The upstrokes were brisk, smooth, and rapid as to be expected. I'm going to ask the patient now to hold their breath for about 15 seconds. I'm going to listen for bruit with both the diaphragm and the bell. Hold your breath, please. And then switching to the bell. And no bruit is noted at this time. Next, I'm going to move on. You can breathe again. I'm going to listen to the patient's heart sounds. I am going to first start on the right side at the second intercostal space, listening for the aortic valve here. And then I'm going to move across to the left second intercostal space, where I'm going to be listening to the pulmonic valve. Going down to the third intercostal space, I'm going to be listening at the Erb's point. At the fourth intercostal space, I'm going to be listening to the tricuspid valve. This also represents the lower left sternal border. Here, S1 is greatest and loudest. And then at the medial aspect of the midclavicular line, at the left fifth intercostal space, I'm going to be listening to the mitral valve or the apex of the heart. Both the apex and the lower sternal border, not only do I want to listen to it with the diaphragm, but I also want to listen to it with the bell. I can actually listen to all the areas with the diaphragm and then the bell. I'm going to be listening for the S1, S2, and physiological splitting of S2. What you find at the base of the heart is that the S2 is greater than the S1, and at the apex of the heart, the S1 sound is greater than the S2. For this patient, I didn't hear any abnormal heart sounds or murmurs, but to test for that, I'm going to ask the patient to step up on the exam table, lying on their left side. I'm going to use my stethoscope and the bell of the stethoscope held lightly on the area of the apical impulse. And what I'm going to do here is listen while the patient is in the left lateral decubitus position, just ever so lightly held on there for any mitral stenosis, which I'm not hearing. And then I'm going to ask the patient to sit right on the edge of the table and lean forward with the diaphragm of my stethoscope. As they lean forward, I'm going to be listening on the left sternal border near the apex as well for any aortic regurgitation. Stop breathing, please. After you exhale completely and then stop breathing. And what I'm listening for right now is that aortic regurgitation, which is not happening. So there's no murmurs or any extra sounds. Next, I'm going to go on to the lung sounds. I'm going to ask the patient to come back and sit so we can see better. I'm going to look for any obvious signs of respiratory distress. I'm going to observe for symmetry of the chest with a rise and fall. I'm going to test for tactile fremitus, where I'm going to palpate both lungs. while I ask the patient to say 99, and I'm listening for symmetrical vibrations. So starting at the front, I'm going to ask the patient using the ulnar aspects of my hands. Please say 99.
99, 99, 99, 99, 99.
Very good. I'm going to go to the back side, and I'm going to have them do the same thing again.
99, 99, 99, 99.
Very good. So feeling those vibrations symmetrically is a good indication that the bronchial tree is acting appropriately. Was there any pain or tenderness while I was palpating? Good. Now we're going to percuss the lung fields using the ladder pattern. I'm going to start on the front side. And what I'm listening for is resonance versus dullness. And then doing the back side, a similar ladder pattern. On the back side, there's a total of 14 points that are percussed above the diaphragm. And on the front, there's a total of 12. And what I'm finding so far is that there's resonance throughout. Now I'm going to auscultate for the lung fields, asking the patient to breathe with their mouth wide open. Nice deep breaths in and out, please, with the mouth open. And what I'm listening to, thank you. And as I listen, I'm not finding any abnormal sounds at this time. The breath sounds so far are vesicular and adventitious. As I move down the ladder on the back side, I'm still not hearing any abnormal or adventitious sounds. So I'm going to say that this patient's breath sounds are vesicular with no adventitious sounds. Next, we're going to move on to the abdominal assessment. I'm going to ask the patient to please come lie on the exam table on their back with their abdomen exposed. Looking at the patient's abdomen, I want to check the skin for any striae. I want to look for any scars, tattoos, masses, or bulges, any rashes, ecchymosis, dilated veins. Looking at the contour of it, I see that it's flat and slightly rounded. It appears symmetrical. There are slight pulsations from the aorta. I'm checking the umbilicus for its contour. Next, I move on to auscultation of all four quadrants. I'm going to listen and move about the abdomen in a clockwise fashion, starting in the right lower. What I'm hearing are normal reactive bowel sounds from the patient. I'm then going to listen over the aorta that lies between the nipple line and the umbilicus, and I'm just listening here for any bruits. I'm also moving over to the lateral aspects from the aorta to the renal arteries for bruits. Moving down roughly in alignment with the umbilicus, I'm listening to the iliac arteries for any bruit, and I'm not hearing any bruits, so that's a normal finding. Using the bell of the stethoscope, I'm going to come over and listen over the area of the right upper quadrant near where the liver lies. I'm listening for any hepatic arterial bruit, any venous hum or friction rub, all of which would be abnormal. I don't want to press too hard when I do this so as to create any false signs. I'm also going to listen for friction rub over the spleen, and I'm not hearing anything, so that is a good finding. I'm going to then move on to percussing all four quadrants. I'm listening for sounds of tympany versus dullness. This abdomen is all tympany sounding, which is a normal finding. That is what I would expect. Dullness would indicate a mass or an organ. I'm going to palpate each of the four quadrants, first lightly, getting the patient used to the movements, and then a little bit deeper. I'm looking to see if there's any guarding or rebound tenderness if there's any masses or any other abnormal findings that I should note. For this patient, their abdomen is soft, non-tender, and no masses noted. Next, I'm going to palpate the aorta. I'm going to just put my fingers on either side of it and press in to feel the pulse on the diameter. Listening or feeling for this rather, I'm noting that it's about 2 to 2 2/4 centimeters between my fingers. That represents the diameter of the aorta. That's normal. I'm going to next percuss for the liver. The liver span, I'm going to start the lower border at an area of tympany until I reach the lower border of dullness. Starting at about the nipple line, I'm going to do the same thing, and I'm looking for the upper border of dullness. And what I'm finding is that area right now from the right midclavicular line from the upper to lower border of dullness is about a span of about 7 centimeters. Next, I'm going to palpate for the liver edge, which should be soft and smooth. I'm going to do the hooking method. I'm going to ask the patient to take deep breaths in, and I'm going to palpate for that liver. I'm not feeling anything on the hooking process. Therefore, there's no hepatomegaly or no swelling. I'm going to then check the spleen. I'm going to percuss it at the lowest left intercostal space at the anterior axillary line. I'm again listening for tympany, which I'm finding it to be tympanic. I'm going to ask the patient to take a nice deep breath in, and I'm going to percuss again. Again, it's nice and tympanic, so there's no splenomegalia. I'm going to ask the patient to please sit up and just face the camera at this angle. I'm going to have them expose their back for us, please. And we're going to do the costovertebral angle tenderness to check for any kidney issues. Going down to that angle, the last rib where it meets the vertebrae, with the non-dominant hand, I'm going to strike it with a punch. With the dominant hand, yes, the patient will jar forward, but was there any pain with that, sir?
No.
And again, on the other side, was there any pain? No. So that's a normal finding. After that, I'm going to check the pulses for the patient. I'm going to start on the radial aspects of the arms. I'm just feeling on the radial part on the flexor surface of the lateral wrist. What I'm finding is that that patient has a 2+, a +2, which is an excellent pulse. Bilaterally, the radial pulses are equally strong and within normal limits. Asking the patient to lay down, please. I'm going to now palpate for the femoral pulse. The femoral pulses lie in between, they're midway between the anterior superior iliac spine to the symphysis pubis. And if I feel roughly in that area, I can palpate positive femoral pulses. They're +2. You have to press kind of deep for these pulses to be palpated. In the lower extremities, I'm going to check the popliteal, which is right here with a slightly flexed knee. I'm going to press in on that patellar fossa, popliteal fossa rather. Feeling that, that's a 2+ on the left. Feeling it on the right, it is also a +2. The posterior tibial, to feel that, I'm going to actually ask the patient just to put their foot up here. It's going to be just behind and slightly below the medial malleolus on both feet. I hear for this right, I feel a 2+. The dorsalis pedis is on the dorsum aspect of the foot. Feeling that, it's also a 2+. I'm going to do the opposite side. And as I'm doing this, I'm also going to be checking the patient's lower extremities for any edema. On our left side, our pulses, both places are 2+. To check for pitting edema, I want to squeeze the top and bottom dorsums of both feet for about 2 seconds. There's no edema, no pitting edema. I'm going to press behind each of the medial malleolus, again for about 2 seconds. There's no depression. And then again, on the shins, no edema is noted. The skin overall on the upper and lower extremities is pink. There's no pallor, there's no cyanosis. It's clean, dry, intact, and warm, and the capillary refill is less than 3 seconds. I'm going to ask the patient to sit up. Neurologically, during the exam, I've observed the patient's affect to be bright and appropriate. Their mood is euthymic, meaning it's normal. I'm going to ask the patient to smile as part of the neurological exam. Please smile, looking for symmetry. Raise your eyebrows and puff your cheeks out. Again, all of this is symmetrical, which means the neurological system is intact. I'm going to test limb strength next. I'm going to ask the patient to first hold their arms up, noting that 5+ for limb strength is representative of active movement against full resistance without evident fatigue, which is a normal finding. So flexion of the biceps, I'm going to have the patient pull against my hands. Both of those are a +5. Now I'm going to have them push down with the right against my hand, and I'm going to feel for the triceps again. Good. So we have a +5 with the extension of the triceps. On the deltoids, I'm going to have the patient first with their arms slightly bent and slightly up. I'm going to have them push, and that tests the anterior. Then I'm going to have them resist the push, so push up and resist. And then for the interior, pull forward. Great. So the patient on this side, the deltoids are +5 from the anterior, medial, and posterior. Again, I'm going to have the patient resist and resist and resist. Very good. +5s throughout the deltoids. Next, I'm going to test the flexion at the hip. I'm going to have the patient bend their knee up and resist as I push down. Same thing again on this side. Very good. And then for the extension of the hip, I'm going to ask the patient to lie down onto their belly with the back of their legs exposed. And we're going to test the extension of the hips. Okay, I'm going to have you push your leg up and resist. Very good. And again on this side, same thing. Excellent. We have 5+. For hip abduction, I'm going to have the patient attempt to spread their legs apart using the hips. Good, and resist. And then again on the adduction, pressing their hips in. Very good. That's a +5. Next, we're going to test the quads. I'm going to press here and have the patient resist. Very good. That's a +5. To test the gastrocnemius, I'm going to have the patient pull against so the patient is going to dorsiflex and plantar flex their ankles, and they're going to resist me as I do this. So they're going to first, very good, feet up and push, good, and then pull, very good. So our patient has +5 on the gastrocnemius, noting the calf strength on both sides. Bilateral hand squeezes are next. Those are a 5+. The pronator drift, I'm going to have the patient stand up with their palms out, and as palms up, very good, I'm going to press, and they're going to resist. That's a +5 as well. Next, I'm going to test their reflexes, so I'm going to ask the patient to sit down. I'm going to start with the plantar reflex, and just relax your leg, please. Good. Good tone. Very good. Notice with the plantar reflex, I'm using the pointed edge of the mallet. Now for the Achilles tendon, I'm going to strike it with the straight edge. I'm going to strike and have the patient, very good. There's going to be some good dorsiflexion there in those feet. Next, I'm going to have the patient stand up and walk across the room. We're going to be observing for a couple of things. First, I'm going to have them tandem walk, looking at their balance and their arm swing, then walk on your toes, and then your heels. And what we're going to look for is that their balance is intact, that their arms swing symmetrically at the sides, and that their turns are smooth. This concludes the final head-to-toe assessment. Thank you for watching.